on 26th of July 2021, Monday, there was this first semester end exam of MBBS 2020 batch held at Rajshri Medical Research Institute, Bareilly, and this was of anatomy. So this question paper was of 100 marks, which included part A of 20 marks and part B that was of 40 marks and part C of 40 marks. Those B and C were subjective and part A is of 20 MCQs. So here I'm going to solve all these 20 MCQs for you. So keep watching, keep assessing yourself. I'm going to explain these questions for you. Starting with question number 1. Vertebral column is narrowest at which vertebral level? C6 and C7, C7 and C8, T4 and T5, or T12 and L1. So I have already explained you this thing in one of my lectures on the board. There's a video uploaded, you can check it out from there. So while looking the spine from a distance, like more than 6 meters, when you see a vertebral column, it appears like this. This one is C1. This is at the level of C7, T1, and here it is T4, T5, and this is L5, S1, coccyx. So remember this always, that this vertebral column is narrowest at the level of T4, T5, except at the terminal ends. Like coccyx and C1 you can spare because those are the terminal ends. So in between, this vertebral column is narrowest at the level of T4, T5. So the answer is C. So the next question is, growing end of long bone is. This I have already taught you. There is a video uploaded upon the growing end of the long bones. For details, you can check it out from there. But here I'm going to just summarize you about the facts about the growing end of long bones. So growing end of the long bone is, the choices are that it's a bulkier end, first to start ossification, it is first to complete ossification, it is in the direction of nutritional foramen. Okay, so let me revise it for you so that you can remember it once again. Criteria for identifying the growing end of the long bone is, I told you that we remember the growing end of the long bones with this fetal lying position, right? So if this is the fetal lying position, right? So in the fetal lying position, the orientation of the long bones is like this. You have, radius ulna here, humerus here, femur here, tibia fibula placed here, and clavicle, it's here. So there are 7 pair of long bones. Now remember, the criteria says that the ends of the long bones in the fetal lying positions which are nearer to the head are the growing ends. So in case of humerus, it's the upper end. In case of ulna and radius, it's the lower end. And in case of femur, it's the lower end. Tibia and fibula, it's the upper end. And about the clavicle, as you know, the end nearer to the head is the growing end. So in clavicle, it is the medial end that is the growing end. Then another criteria says, you remember that diagram what I had drawn earlier? So when you're going to water a plant, I told you this diagram so is to remember that when you're watering a plant, that means the nutrition being provided to the plant is going downward direction, but the growth of the plant happens in an opposite direction. So this diagram was to remember that the fact that the nutritional foramen is directed opposite to the growing end, or the growing end is opposite to the direction of the nutritional foramen. So these 2 facts you need to remember. And the third thing is that the bulkier end of the long bone is generally the growing end. But because there are exceptions, remember ulna being an exception, ulna, the growing end is not bulkier, which is the distal end, which is narrower. And another criteria of identifying the growing end is that the growing end is first to start ossification and it is the last to complete ossification. First to start and last to complete ossification, and that's why it becomes bulkier also. So let's see the choices here. Bulkier end, of course it is correct, but it has an exception, with exception. So this is with exception. And choice number B is first to start ossification, that is correct. First to complete ossification is wrong. It is the last to complete ossification. It is in direction of nutritional foramen, wrong, because it is opposite to the direction of nutritional foramen. But because you have to select the most appropriate answer, choice number B will be the more appropriate answer. Moving on to next question, question number 3. Which muscle of upper limb takes origin from the 3 bones, humerus, radius and ulna? The choices are flexor digitorum superficialis, flexor digitorum profundus, extensor digitorum supinator. This is what I'm drawing is the anterior view of the lower end of right humerus. This point, here it is the anterior surface of the medial epicondyle, which is the common flexor origin. And then at the upper end of the ulna, medially, there also is origin of this muscle. And here on the anterior surface of the radius, there's an oblique line which also provides origin to this muscle. So this muscle takes origin from the 3 bones. I hope you've guessed the answer by now. This muscle takes origin like this. When it reaches below to the flexor retinaculum, it actually is a superficial muscle, but it is placed in the intermediate compartment below the superficial muscles and above to the deeper group of muscles. So when it passes below the flexor retinaculum, it splits into its 4 tendons, right? These tendons cross the metacarpophalangeal joints, then they split here at the level of the proximal IP joints and then get attached on either side of the middle phalanx. So in between, they provide space for the passage of the deeper tendon, flexor digitorum profundus, like this. This muscle is flexor digitorum superficialis. Flexor digitorum superficialis takes origin from the 3 bones, humerus, radius and ulna, and it embraces the tendon of flexor digitorum profundus at the level of second phalanx and attaches on the either side of the middle phalange. So the answer is A, flexor digitorum superficialis. Okay, so the next question is question number 4. Which plane does not fix the pelvis in anatomical position? Pubic symphysis and coccyx should be in the same horizontal plane. This is a correct option. Next is ASIS and sacral promontory should be in the same transverse plane. Remember that this also is a correct option. Then ASIS and pubic tubercle should be in the same coronal plane. This also is a correct option. So the choice number D is acetabulum should be facing laterally backwards and downwards. This is a wrong option, but this becomes your answer because they've got not fixed, right? So the answer here will be this one, option number D. Acetabulum should be facing laterally forwards. This backwards should actually be forwards. and downwards. Next question here is, bony factor is the main factor of which arch of the foot? Remember that when you're talking about the arches of the foot, you should know what we're talking is about. So regarding the arches of foot, you should know that there are four arches, right? So you have an anterior transverse arch here at the level of head of the metatarsals, and you have a posterior transverse arch at the level of distal row of tarsal bones. And here you have is the medial longitudinal arch, and here you have is the lateral longitudinal arch. So the bony factor, there are actually 7 tarsal bones, right? The calcaneum, talus and navicular bone, they are placed posteriorly, but distally the 4 tarsal bones, they are placed linearly. And remember that the distal tarsal bones, they are wedged. So being wedged means what? That they have the dorsal surface which is wider and the plantar surface is narrower. So when they're aligned against each other, they form this type of arch, and that is the plantar tarsal arch formed by the distal row of tarsal bones. So this is medial cuneiform, this is intermediate cuneiform, this is lateral cuneiform, and this is cuboid, right? So obviously we have drawn is a cut section of the right foot, and you can presume that this is the cut section of the foot. So there are lot many factors which maintain, there are muscles also. There was this tibialis anterior reaching down here, as well as, there was this base of the metatarsals attached here, right? Base of the metatarsals attached here. So this muscle is tibialis anterior, and here you have is peroneus longus, which also inserts onto the same bones, and this is peroneus longus. Peroneus longus actually passes behind the lateral malleolus, and this passes, tibialis passes anterior, and this is medial malleolus. Tibialis anterior descends anterior to the medial malleolus. Peroneus longus descends behind to the lateral malleolus. Both of them, and this, this bone, this peroneus longus, it grooves the cuboid on the undersurface, forming this cuboidal tunnel, like this. So ultimately, both these muscles, tibialis anterior, peroneus longus, they form a sling into which your foot is placed. So when they pull up, right? So actually your metatarsals and the tarsals, they get gripped transversely, and that also helps to, and that also supports the maintenance of this posterior transverse of the foot. Of course, tibialis anterior will also help in inversion and maintaining the medial longitudinal arch. Peroneus longus will help in eversion, will also help in maintaining the lateral plantar arch. But the sling helps not only to maintain the posterior transverse arch, because gripping the metatarsals and the tarsals also helps to bring the head of the metatarsals closer. So it also helps in maintaining the anterior transverse arch, as well as because tibialis anterior is pulling the medial longitudinal arch and peroneus longus is pulling the lateral plantar arch. So in together you can say sling is one factor which helps to maintain all the arches of the foot. Then other factors include, there is this muscle here which is descending behind to the medial malleolus, right? And it reaches to the navicular bone. From navicular, it spreads to all the tarsal bones, including the middle 3 metatarsals, except the talus. And it even reaches to the head of the metatarsal and is attached to, crosses the head of the metatarsal and is attached to the proximal phalange of the greater toe medially, and that is the medial head of flexor hallucis brevis, which is supposed to be detached tendon of this muscle. So you should guess that this muscle is tibialis posterior. So there are so many factors which help in maintenance of this posterior transverse arch, of which the bony factor is the main factor. Okay, now question number 6 is integrity of the superficial inguinal opening is maintained by Poppert's ligament, ligament of Cooper, Fox inguinal, intercrural ligament. This I believe you should know. I'm drawing it here for you. This is ASIS, this is pubic tubercle and pubic crest, pubic symphysis, right? And this is the inguinal ligament. Here you have is the superficial inguinal opening, right? So Poppert's ligament is nothing but it's another name for this inguinal ligament, right? So this is choice number A. Then there is ligament of Cooper. Ligament of Cooper is, this inguinal ligament, it reflects onto the pectinate line on the pectineal surface of the pubis, and this is called pectineal ligament or ligament of Cooper. Then you have is Fox inguinal. Now Fox inguinal is another name for this. There are fibers of internal oblique forming the roof of the inguinal canal like this, arching above, and then together they condense, and that is called conjoint tendon. This conjoint tendon of the two muscles is also called Fox inguinal. And you have this medial end of the inguinal ligament where this turns behind to form the pectineal ligament. You have this semilunar horizontally placed ligament that is called lacunar ligament, which forms the medial boundary of the femoral ring. And here in the median plane you have is the linea alba. So from the medial of the inguinal ligament there are fibers reaching up behind to this opening of superficial inguinal ring. This is the reflected part of inguinal ligament. And one more thing, I'm just reminding you all the ligaments here. There is occasionally present, not always, this ligament which binds the lower fibers of the internal oblique down below to the inguinal ligament. This ligament is interfoveolar ligament. And then one more thing I should add here, this is the superficial inguinal ring, which is an opening in the aponeurosis of external oblique. Then these fibers here you can presume that the superficial inguinal ring is made by two crura, which are like thickening of the aponeurosis. So these are the intercrural fibers, right? So the intercrural fibers, they pull this apex of this which is in like obtuse triangle like superficial inguinal ring. So at its apex it's being pulled by the intercrural fibers both the sides so that it doesn't collapses down. And of course it is a factor which helps to close and to approximate the two crura, in thereby helping to maintain the integrity of the superficial inguinal opening, and this is called slit valve mechanism. So I hope you understood. Let me name them one by one so that you can remember. This was Poppert's ligament, choice number A. Ligament of Cooper is this pectineal ligament, I told you, number B. And Fox inguinal is the conjoint tendon, number C. And intercrural fibers are number D. I additionally told you this one more, as you can remember, choice number E is interfoveolar ligament, and of course I told you this one also, and that is choice number F, and that is reflected part of the inguinal ligament. So there are 6 such ligaments you should know regarding to the mechanism of the inguinal canal. By the way, here the answer will be intercrural ligament. Okay, now we're talking about question number 7. Which of the following is not a feature of typical lumbar vertebrae? So first of all, you should know what is a typical lumbar vertebrae is L1 to L4. Only the fifth lumbar which mimics features of sacral vertebrae. So that's L5, which is atypical lumbar vertebrae. Otherwise 1 to 4 they are all typical vertebrae. So typical lumbar means they will be having all similar features. So here I'm drawing this diagram, so I hope you can understand this. Lumbar vertebrae, one feature is that it has the reniform or the kidney shaped big bulky vertebral body. Pedicles are short although, and it has this transverse processes which posteriorly has a tubercle, and these tubercle are called accessory processes, which are actually the true transverse processes. Remember that the transverse processes of a lumbar vertebrae are derived from the costal elements, so these are false transverse processes in lumbar vertebrae. The actual transverse process is this, that is the accessory process lying behind posteriorly on the transverse process. Then you have here, it's this superior articular facets which are directed backwards and medially and having a articular surface which is bulkier at the lower end. This becomes thickened at the lower end, and this is called the mammillary body of a lumbar vertebrae. Similarly, there will be articular processes facing downwards. I mean, they're projecting downwards, and these are facing forwards and laterally. This is the direction of the inferior articular facets, facing down, forwards and laterally. The superior articular facets are directed posteriorly and medially. And then in between you have is the transverse process. This transverse process is, I'll show you in a later view, it is quadrangular in shape, and it is like not at all pointed, it is blunt. And you can complete this diagram here this way, right? So, and now another important thing is that the vertebral canal here is triangular in shape. Remember that the vertebral canal in the lumbar spine is triangular in cut section, right? So that was in a superior view of a typical lumbar vertebrae, but when you see it in a lateral view, you will find that it is actually like this. And here you have is the superior vertebral notch, and here it's the inferior vertebral notch. So the inferior vertebral notch is deeper and the superficial vertebral notch is a shallow notch. And then here you, as I told you already, it will be the superior articular processes. Here it will be the inferior articular processes, and of course the spine. Here I told you this will be the spine, and then here it is how there you will find is the transverse, the spinous process lying posteriorly, which is somewhat quadrangular in shape, and here it will be the triangular vertebral canal. And one more thing that you noticed here, that the anterior surface of the body of vertebrae, the thickness is more, and posteriorly it is less in thickness. And that's the reason here when you place these lumbar vertebrae one above the another, they will form an anterior convexity. That's the main bony reason for formation of this lumbar lordosis. That lumbar spine is convex anteriorly because these lumbar vertebrae they are wedge shaped. They have an anterior surface which is wider, but the posterior one is narrower posteriorly. So I have given you all of these reasons. So in case if it's asked how to identify these lumbar vertebrae, point number one, there should be no foramen transversarium, which of course is a feature of cervical vertebrae. Then there should be no costal facet, and costal facet is a feature of thoracic vertebrae. So if you're not having these two typical features, that means that the vertebrae placed in front of you will be a lumbar vertebrae with a big body and all those features I've already told you, because the rest of the vertebrae down below, the sacral vertebrae, they all fuse to form synsacrum and syncoccyx. Got it? Okay, so the answer here will be, let me read out. Which of the following is not a feature of a typical lumbar vertebrae? Width of the body is more anteriorly than posteriorly. I have just shown it here in front of you. This is the reason. Vertebral canal is oval in shape. Can you see this vertebral canal? It is triangular in shape. Spine is short and quadrangular. I have just shown you that its spine is small and quadrangular. Superior articular processes are wide apart. Yes, you should remember that these superior articular processes are wide apart and the inferior articular processes are closely placed. So it's correct. Now what the question is asking is not a feature of typical lumbar vertebrae. So the answer will be B. So remember that the typical lumbar vertebrae, the vertebral canal is triangular in shape. Now question number 8, which opening of diaphragm lies opposite to T9 vertebrae? Vena caval opening, esophageal opening, aortic opening, foramen of Morgagni. This also I have taught you in one of my lectures regarding the vertebral level of body parts. So this you presumed as manubrium, then you have the body of sternum, this is the sternal angle, and here you have is the spine, thoracic spine. This is T1, T2, T3, T4, and this will be T12. This is the first rib. So first rib reaches to the first thoracic vertebrae, and this also this is a transverse plane passing between T4 and T5. So this is the plane of sternal angle, and this is the plane of thoracic inlet, that is between T2 and T3. Because thoracic inlet is obliquely placed, making an angle of 45 degrees with the horizontal. Then talking about the diaphragm. So diaphragm here, diaphragm is arched like this. So remember that the diaphragm, the apex, the highest level of the dome of the diaphragm, that reaches at the level of T8. And at that same level, you have is an opening here. And this opening is called the vena cava opening. Vena cava opening. It's a tendinous opening, and from where inferior vena cava passes along with the right phrenic nerve. Then you have is the esophageal opening here. Esophageal opening allows the passage of esophagus. Esophagus passes here, this opening. Now this opening lies at the level of T10, that is esophageal opening. Through this esophageal opening, what passes is the esophagus, then the esophageal vessels. These are the branches of left gastric artery and tributaries to the left gastric vein, and of course the right and left vagus. Then down below here also you find is an opening with the two crura, right and left crura. This opening allows the passage of the abdominal aorta. So this opening lies at the level of T12, that is aortic opening. Aortic opening allows the passage of abdominal aorta, and to its right you find is azygous vein ascending up and the thoracic duct. Now one more opening is left behind, and that is a minor opening. This minor opening lies at the level of xiphisternum, costo-xiphisternal angle, right? At that point, you find is a minor opening in the diaphragm, and this opening, of course, is below to the highest level of the diaphragm, that is the dome of diaphragm. So this opening lies at the level of T9, and this opening is called foramen of Morgagni, or some authors also write it as Larry's space. This is also called Larry's space. So what does it allow to transmit here? Remember, it is this superior epigastric artery. So superior epigastric artery passes through this, of course, with its vena comitatus also. So I hope you got the answer now. Question number 8, which opening of the diaphragm lies opposite to T9 vertebrae? Its answer is foramen of Morgagni. Now the next question is question number 9, which lymphatic organ is partially encapsulated? So very important and easy question. Remember, all these lymphoid organs, they are encapsulated except the tonsil. Now tonsils actually are many in number, but by default when we write only tonsil, we are, and by default it's a convention that we understand tonsil means palatine tonsil. Otherwise you have lingual tonsils, tubal tonsils, and abdominal tonsils, lingual tonsils, so many tonsils. But if it's said only we're talking about tonsils, so that means by default we're talking about palatine tonsil. And remember that palatine tonsil, the portion of the palatine tonsil that projects in the oral cavity between its two pillars and tonsillar pillars. One anteriorly it is the palatoglossal, posteriorly it's the palatopharyngeus. In between it's the tonsil that projects medial in the oral cavity. So only that portion of the tonsil is covered by the oral epithelium, that is stratified, squamous, non-keratinized epithelium with crypts, and one of those crypts is a large crypt called crypta magna, right? So while the rest of the portion of the palatine tonsil, which is embedded inside, deep inside, that is not covered by any capsule. So the answer here is, that answer is tonsil. Now next question is question number 10. What type of collagen fibers are predominantly present in spleen? Type 1, type 2, type 3, type 4. Remember, there is already a lecture uploaded in my playlist. You can see the details there. It is titled as OSPI on connective tissue fibers. You can note the details from there. It's already given in OSPI on connective tissue fibers. The answer here will be, because spleen is a reticuloendothelial tissue, and in the reticuloendothelial tissue you find more of reticular fibers. So type 3 collagen is also called reticular fibers, and the classification of this collagen fibers is according to the thickness. Remember, type 1 is the thickest. So remember about type 3, and to know the details of all such examples, there are even more subtypes. All of them they explain in detail in this OSPI on connective tissue fibers. Question number 11. Stratified squamous non-keratinized epithelium is present in all except inner surface of tympanic membrane, pecten of anal canal, tonsil, esophagus. Just now in the previous question, you've seen that I taught you about tonsil. So tonsil is lined on its exposed surface by stratified squamous non-keratinized epithelium. And you know that this oral mucosa, the same epithelium continues down in the pharynx, reaching down to the esophagus. So even esophagus is lined by stratified squamous non-keratinized epithelium. Then talking about pecten of anal canal, this I'm going to explain it here. This consider is to be a anal canal, and that this anal canal here, it has this internal anal sphincters like this, and then here you have is external anal sphincters like this, and this anal canal in its upper 1/3, these are anal columns and the walls, anal walls, and below to them, that forms a line, and this line is called pectinate line. Then here at the lower 1/3 you find is another line, and this is called white line of Hilton. And the area in between here, this area here in between is called pecten, because just beneath to the mucosa here you find is the venous plexuses. So the lining epithelium we're talking here is about, the lining epithelium here is the skin. Skin is stratified squamous keratinized epithelium in the lower 1/3. By the way, the measurements, let's also write down these measurements. This we divide anal canal into 3 portions. This upper one is 15 millimeter and middle also is 15 millimeter, and this one is 8 millimeters. So that makes it 3.8 centimeters. So remember, this length of anal canal is 3.8 centimeter, and there's one another canal that also is 3.8 centimeter, and that is inguinal canal. So the lining epithelium of this portion here, the lining epithelium of pecten, that is above this line of Hilton, this lining epithelium here, it is by stratified squamous non-keratinized epithelium, and this portion of anal canal above to the pectinate line, this portion here, this is the continuation of the rectum. So the lining epithelium will be stratified columnar epithelium. Okay, so don't forget about this line of Hilton. So I hope you understood about pecten of anal canal, that is lined by stratified squamous non-keratinized epithelium. Lastly, now talking about inner surface of tympanic membrane. So for this, you understand what I'm drawing here. It is the external ear, and this is the external auditory meatus, and here it is the tympanic membrane. Here it is the cavity of the middle ear, and that is communicating through the auditory tube to the nasopharynx. So the lining epithelium here in this auditory tube up till this cartilaginous portion is respiratory epithelium, and here you have is the internal ear like this. So you're getting what I'm trying to explain you is the lining epithelium here, it is respiratory epithelium in the auditory tube up till its cartilaginous portion. Then in the bony portion of this auditory tube or eustachian tube, which continues to line the middle ear cavity, and it even lines the tympanic membrane from the inside, as well as the ear ossicles also. Everything here in the middle ear is lined by the same epithelium, and this is simple cubical epithelium. Lining epithelium within the internal ear, that is simple columnar ciliated epithelium. The lining epithelium here in the external auditory meatus, which also lines the tympanic membrane on its outer surface, is nothing but the same skin. So this is stratified squamous keratinized epithelium. I hope you got to know about the tympanic membrane, both the surfaces, outer surface stratified squamous keratinized epithelium, and the inner surface is by simple cubical epithelium. So answer here is that inner surface of the tympanic membrane will be your answer. That is what they have asked. which is not lined by stratified squamous non-keratinized epithelium. Rather, it is lined by simple cubical epithelium. Next question is structures in the floor of the auscultatory triangle are all except. You presume I'm drawing the right shoulder, the scapular region from behind like this. This is scapula. And here you have is the spine. This is the spine. This is the iliac crest. So it's this muscle here, you must be knowing that it reaches here to attach to this scapula like this, and this is trapezius. And another muscle here, it takes origin from the iliac crest, sacral spines, lumbar spines, and the lower 6 thoracic spines. It winds this, lower back like this. This is latissimus dorsi. The triangular area here left between this triangular area has another muscle in its floor, and that muscle here is rhomboideus major. Now, apart from that, it also has ribs. You find 6th and 7th ribs in its floor. This is 6th rib and the 7th rib. The muscle here, it is rhomboid major. And which space will be between 6th and 7th rib? Will it be 7th intercostal space or the 6th intercostal space? Of course, it will be the 6th intercostal space, because the intercostal spaces are numbered according to the rib higher above. So I hope you've got the idea about this auscultatory triangle, but still there is a lot more to know, and all the rest of the things you can find it in the lecture uploaded separately in my playlist that is on triangle of auscultation. So the structures in the floor of auscultatory triangle are all except 6th and 7th rib is there, 6th intercostal space of course is there, then rhomboid major muscle is there. Rhomboid minor muscle is not a content of the floor of the auscultatory triangle. So the answer is D. Next question is regarding the structures in the space of burn are all except. So you should know what is space of burn. So look here, like what I'm drawing here is the suprasternal border. This is the suprasternal border, and this is manubrium. So onto this manubrium, you find it will be clavicles attached both the sides like this, and of course there will be first rib also attached. These clavicles, they form this joint here. This is a saddle variety of synovial joint, which is a complex joint with an intra-articular disc, and this joint is sternoclavicular joint. But remember, the two clavicles are also held together with the help of this ligament, and this ligament is interclavicular ligament. And you know that there are anterior jugular veins coming from above like this. These two anastomose here, and they form the anterior jugular arc. Apart from this, you will also find there are suprasternal lymph nodes placed here. These are suprasternal lymph nodes. Then, this muscle, sternocleidomastoid. This muscle is sternocleidomastoid like this. So this muscle has two heads of origin. It also takes an origin from the clavicle, the medial 1/3 to 2/3 on its superior surface. This provides origin to another head of sternocleidomastoid. Now what is left in between here is actually a triangle. This triangle left out in between, this triangle is inferior or lesser supraclavicular triangle. In case if they ask, like if you prick a needle here in between in this lesser supraclavicular triangle, which structure is going to be pierced? The answer is internal jugular vein. So what structure lies behind to this? inferior supraclavicular triangle? The answer is internal jugular vein. Now coming back to the question here, structures in the space of, let me tell you first of all before that, that is about the space of burn. So what is space of burn? Now I'm drawing here, it is a sagittal section here, or the median section. So this is the manubrium that you'll find in a cut section. And you know that the deep fascia of the neck has a lot of modifications, and we call the deep fascia of the neck as fascia coli, Colles fascia. Now the Colles here is different from perineum. In the perineum you have COLLE that surrounds the scrotum, and in the neck you also have a fascia coli. Now this is COLLI. So remember this difference. This fascia of coli in the neck has a lot of modifications. So one of its layers superficially which invests the muscles sternocleidomastoid and trapezius, that investing layer of the cervical fascia, it descends down and it splits to enclose this manubrium like this. So the space formed just above to the suprasternal notch, because of the splitting of this deep fascia of the neck, this is called suprasternal space of Burns. Okay, now let's come back to the question. Structures, question number 13, structures in the space of Burns are all except suprasternal lymph nodes. I have told you they will be there. Interclavicular ligament, that will be there. Anterojugular venous arc will be there. Now talking about fleshy fibers sternocleidomastoid muscle, so you should know that in the longitudinal axis of this muscle sternocleidomastoid is the sternal head, and this sternal head of sternocleidomastoid is tendinous, while its clavicular head is fleshy. So the answer, remember, is fleshy fiber sternocleidomastoid muscle will not be a content of space of Burn. It will be arising from the clavicle outside the space of Burn. So the answer here is D. Next question is regarding the length of chromosomes is best observed during which stage of cell division. So it might be mitosis or it might be meiosis. Cell division happens, both type of divisions, whether it may be reduction division or maybe simply division. So what happens here in this stage, what I'm telling here, remember that these chromosomes, they come in an alignment in the equatorial pole like this. So when these chromosomes, they come and align at the equatorial pole, they are attached to these spindle fibers made up of microtubules. They are pulled on the opposite poles by the centrioles. Look here. Next, what happens is these chromosomes, they are pulled to the opposite direction. Now it can be seen the two arms of the chromosome, P and Q arms of the chromosomes being, or you can say the position. Now in this phase, both the arms of the chromosomes can be seen differently, and because of the pull of these spindle fibers at the opposite ends, the position of this centromere, becomes visible, so that you can differentiate the length of the arms of the chromosomes P and Q. So with this, now you conclude that the length of chromosome is best seen in this stage, and this stage is metaphase. While here you can see actually is the shape of chromosome. This can be better seen here in this stage, and that is called anaphase. So the answer here is, because they've asked the length of chromosome, the answer will be metaphase. Question number 15. In ovary, which cell undergoes first meiotic division? So it's so easy. Remember that the primary oocyte undergoes this first meiotic division, which actually is a reduction division. 2n goes to n and n, right? One will be the ovum of Graafian follicle, and the other will be a polar body, first polar body. This happens here that 2n becomes n and n like this is a reduction division. This happens in the primary oocyte, and the secondary oocyte formed will be haploid, and this one is diploid. The first meiotic division happens in primary oocyte. Question number 16. Out of the different factors, which is the main factor that leads to ovulation? The cells of the cumulus ovaricus becomes loosened by the accumulation of intercellular fluid between them. On the surface of the ovary, an avascular area, that's stigma, appears over the most convex point of the follicle, and increased pressure of fluid in the follicular cavity. Will this be the main reason for ovulation? What they have asked is the main reason of ovulation. The high concentration of LH leads to increased activity of enzyme collagenase, which digests the collagen fibers surrounding the follicle. Option D is increased concentration of the prostaglandins causes contraction of smooth muscles in the wall of the ovary. So what have you concluded with question number 16? Basically, this question is for learning purpose. This purpose I have given purposely so that you can learn the different factors responsible for ovulation. So remember, all of these choices A, B, C, D, they are all helping in ovulation. So this might be asked sometime as a short answer question. So that's why I have given these 4 options so that you learn them. But the question here, it is about the main factor. What will be the main factor? So about the main factor, remember, you have been learning it since your high school 11th metric classes, class 10th, 11th, 12th. You must have heard about this LH surge. This is the high concentration of LH that leads to ovulation. So remember, no doubts about this. This always stays to be the main reason for ovulation, that is LH surge. Increased concentration of LH leads to increased activity of enzyme collagenase, which digests the collagen fibers surrounding the follicle. That's the main reason for ovulation. Now, question number 17 is on percussing the anterior chest wall of a patient. You find the right margin of the heart to lie 2 inches, that is around 5 centimeters to the right of the edge of the sternum. Which chamber of the heart is likely to be enlarged? This is an easy question. Look here, the heart, it's like this, right? And you know, this is like the arch of aorta. And you also know that this is the pulmonary trunk, right? Anyways, and you also know that here it is the right AV sulcus, and here it is interventricular sulcus, and here it is the right auricle, here it's the left auricle. And you also know that heart, it's placed. How is it like? Where actually is heart placed? Heart is a content of middle mediastinum. It lies 1/3 on the right and 2/3 on the left. So remember this all here, like, you know, arch of aorta. This is lying behind the lower portion of manubrium sterni. And this is the sternum. This is the position of sternum. So 1/3 of the heart, it said that 1/3 of the heart nearly lies towards the right of the median plane, and 2/3 nearly or more than 2/3 lies on the left side. So what they have asked is on percussing the anterior chest wall, if you find the right margin of the heart to lie 2 inches to the right of the edge, means what they have they're talking is about cardiomegaly. So if this border is seen to be enlarged, that is there in the question that they have asked, is what will happen if this border enlarges and reaches around 2 inches on the right side of the sternum. So obviously you should know the borders of the heart. Remember, the right border of the heart is formed by right atrium, left border of the heart is formed by left ventricle. This inferior border is formed by mainly by the right ventricle, and to the left little bit here, it also is by left ventricle. Obviously, which chamber of the heart is likely to be enlarged? So what is getting enlarged is this right atrium. Question number 18 is pulmonary unit is a part of the lung tissue which is aerated by. This is easy one. Should remember that trachea divides into two bronchus, that's primary bronchus, then it divides into secondary bronchus like this, right? And the secondary bronchus divides into number of, 3 in upper one, then 2 here in the middle one, and then again 5 from there. So it's like this: primary, secondary, and tertiary bronchus. Tertiary bronchus is segmental bronchus that innervates the bronchopulmonary segment. Secondary bronchus is which aerates the lobes of the lungs. Right. So now these tertiary bronchus, they will further ramify into successive branches. Right. And they will reach to form the terminal bronchiole. Let's say it is a terminal bronchiole. Remember what's the difference between bronchus and bronchiole? Although there are a lot many differences. One major difference, you should remember that bronchus has cartilaginous surrounding and or surrounding its tube. Bronchioles do not have cartilage. Then terminal bronchiole continues as, now I'm using this blue color. So let's presume that this is a terminal bronchiole. This terminal bronchiole will lead to respiratory bronchiole, and respiratory bronchiole is having both type of epithelium, means portion of it is lined by the simple cubical epithelium, which is in continuation with the epithelium of the respiratory airway conduction pathway, and portion of it also has the saculations, the dilatations, which are part of this lung parenchyma. Now this will lead to dilated space, that is alveolar ducts. These alveolar ducts are like this. So this is alveolar duct, then you have alveolar atrium, then you have alveolar sinuses. This is alveolar ducts. Still smaller units, you have alveolar sacs, and to those alveolar sac, if you dilate that alveolar sac, it will be like this. That's the alveoli. So that portion of the airway passage from where the air starts leaking out is called the respiratory unit. What all I have drawn here in blue color is called a respiratory unit. So remember that respiratory unit is aerated by respiratory bronchiole. Bronchopulmonary segment is aerated by segmental or tertiary bronchus. Okay, so the next question here is acetabulum is formed by ilium, ischium, and pubis in the ratio of. This also is an important question. So remember that what I am drawing here is the hip bone like this. It's like this. Here you have obturator foramen, and here you have is the acetabulum. This is the outer view, the lateral view of the right hip bone, and here you have the horseshoe shaped articular cartilage of the acetabulum. So basically, developmentally, this hip bone is formed by 3 bones, ilium, ischium, and pubis. So this acetabulum is actually formed by the contribution from the 3 bones like this. And that's a primary cartilaginous joint. Primary cartilaginous joints are temporary joints. They are there only for the growth purpose, but after adulthood, cessation of growth happens and this undergoes chondrosis. So that leads to cessation of growth and the joint fuses, and that's called skeletal maturity. So you know that acetabulum is formed by the contribution from the 3 bones. This is ilium, this is pubis, and this is ischium, right? So contribution will be 1 is to 2 is to 2. So the answer is ilium ischium pubis. The answer will be 2 is to 2 is to 1. The last question finally, Caput Medusae is seen in case of, this is umbilicus, and during Caput Medusae what happens is there are radiating pattern of veins seen below to this in the paraumbilical region. Now this is because of portal hypertension. When there is blockage of the portal vein, maybe because of hepatic cirrhosis and all, so what happens is that portal vein, there is a portal hypertension created and the blood gushes back to join the systemic circulation. So at places where there is portocaval anastomosis, one of the site is at the umbilicus. So the paraumbilical veins, they join this branches, the systemic veins reaching to the umbilicus. So you will find because of that there will be radiating out pattern at the umbilicus. That is Caput Medusae. Basically Medusa was a Greek god who had like so many snakes coming out from his head. So it's the name given from Medusa, that is a Greek god, and Caput means is the head. So Caput Medusae is seen. And remember, one important fact about this is that this Caput Medusae will follow the watershed line. It will respect this watershed line. This watershed line is of a transverse plane along the level of the umbilicus. So remember, the venous and lymphatic drainage above to this level will be draining upwards, and the veins and lymphatics below to this level will drain down below. Remember that Caput Medusae obeys the concept of watershed line. Today is 28th of July 2021. Okay, done.